colleagues and colleagues. I know we call colleagues when you still haven't finished your exams yet, but you're going to be enjoying medicine. And I think a lot of it is so interrelated that the topic for tonight is really about sexual health and longevity. And I really hope that this will help you in your future, or if you are presently qualified, that it might help you even more in some ways as well. To start off with, I just want to say that when you look at life in general, I think you can notice that almost everything is interrelated, right, for various things. If you have a patient who has got cancer, he's more likely to have cardiovascular disease. If you have a patient who has infections or put on antibiotics, they're more likely to get cancers. Everything is interrelated. And I think one of the most important things is for us to keep our research and our excitement about our field going forward, because I think it's a great honor for you to be a doctor or to be a medical student as well. And you are going to be serving people. And I think it's not just about in the medical field, but it's about in general life as well. And that's why I start with this picture. And I must say, I'm in South Africa, as you said. And in 2012, South Africa was number one in the world for obesity and overweight. We were 30% of our population were obese or overweight. And worse still, 30% of our children are obese and overweight. And it's not that difficult to actually stop this happening. Fortunately, South Africa is now only number 7. But the point is that we need to start addressing not only our own sexual health and life, but also even our children and our colleagues and friends. And I hopefully tonight we'll get some take-home messages that will help you to manage that. By law, I'm a government employee. It sounds cooler when I say federal, but in South Africa, it's actually government. So I have to give my disclosures. If you notice, almost all, basically the 3 main drug producers for PDE5s are here. I'm on their advisory boards and consultancies as well. Okay. Now, sorry, just give me 1 second. Yeah, there's lots of evidence to show that men are more likely to die than women from various causes. And I think, although most of what I'm going to be talking about tonight is going to be about male sexual health, and I will touch on female sexual health at the end, it's really rather more complex than that. And the whole point is that even what works for male sexual health to improve male sexual health also works for the majority of females as well. But females, of course, are a more efficient race. In fact, if you've ever read the Epic of Gilgamesh, the Persian book, it talks about the Tower of Babel, where the original person was a hermaphrodite, male and female. And then when they saw that they were working together so well together, they were getting close to heaven, and they threw a lightning bolt, the gods, and cut it in half, splitting into the women and men into 2 parts. And theoretically, they're supposed to get back together, and then they may become gods as well. And although I'm talking male, female, remember almost everything I'm talking about is also based on sexual orientations as well. It's important for us to all recognize that each person has their own sexual preferences and activities. And at the end, I'm hoping to see that even if you don't feel comfortable about talking about sexuality to homosexuals, to transgenders, to males, females, you should at least make sure that you send the patients to somebody who does feel comfortable, because it's so important to keep the equity amongst the different gender assignments. Now, men, again, we're not equal. Even after the Epic of Gilgamesh, we have things like premature ejaculation, we've got erectile dysfunction. Females also do have some sexual dysfunctions as well, and that's actually almost equal to men, but the point is they're a little more complicated and a bit more clever than guys in general. But regardless, women have a life expectancy of about 7 years more than men. And there are a couple of things we can do to actually change that if we're guys, and I'm going to touch on those as we go along. And this is pretty much the cause. Guys don't take their health seriously. We know that from data that women and male children up to the age of 16 have equal life expectancies and equal chances of getting sick. But what happens at 16 is that the females, again, being clever, say that, listen, my parents were taking care of me. They used to make me go to a doctor once a year just to check for high blood pressure, sugar, this, that, and the other. But the guys say, oh no, I'm feeling fine. I don't need to follow this anymore. So on average, females see their treating physicians 5 times more in their life than males. And that's one of the causes that give us our issues, because we are also more likely to take risks as guys. We're more likely to smoke. We're more likely to take drugs. It's a problem. We need to start addressing our health issues. And again, I repeat, it's not just about males. Even in females, they should also follow the same similar patterns, but guys particularly have an issue. And this is one of the problems. I was talking earlier about the obesity crisis, and this is an MRI of the abdomen. You'll see the yellow part there. That's subcutaneous fat. That's the one that you can do liposuction and stuff for. But the bigger problem is the orange one, what we call the visceral fat, the one around your gut, because we now know that visceral fat is actually an organ. It's like a thyroid. It's like a pituitary. It's producing chemicals which are going into the bloodstream, cytokines and various other chemical hormones, which are actually causing damage to your blood vessels, causing you to get heart attacks, strokes, loss of limb, and cancers. Because remember, the 2 leading causes of death in humans is cardiovascular disease and cancer. And they're probably about equal. And the reality is that they're both interrelated to each other as well. Because if you have a lot of visceral fat, which is part of what we call the metabolic syndrome, where you have visceral obesity, hypertension, dyslipidemia, type 2 diabetes, you are a cardiac risk. You are going to get a higher chances of having heart attacks, strokes, loss of limb. And getting rid of this visceral fat is pretty easy. I'm in Africa, so I'm going to say that there are 5 parts that you must try to remember for any patient that you talk to, or even for yourself. Number 1, diet. And it's not about what you eat, it's the numbers of calories that you eat that's the problem. And I'll touch on that just now as well. Second, a bit of exercise. And exercise, by the way, you don't have to do much, literally 3 minutes per day. And I'll explain exactly why. Third, stress. It's the biggest killer. We also know we've done some rat model, what's it called, trials, putting them under stress. And by the way, how we put them under stress in the cages is by putting smoke in their cages. And once they've been sacrificed, we actually can test the amount of cytokines that they're in their bloodstream. And we now know that stress also causes cytokines to be released, which causes you high blood pressure, dyslipidemia, diabetes, cancer. So stress, you have to be careful. And that's the biggest killer. I always tell my patients, the biggest killer is stress. 4, you must not smoking. Not smoking it's probably the most important social decision you can make. Smoking increases the risk of all cancers, including prostate cancer, which is what I do a lot. It increases the risk of cardiovascular disease. By literally, if you smoke, half of the people who smoke will die from their smoking. And so again, I don't like to pontificate, but the point is it's a really important thing to express to yourself and to your patients. And the 5th one is the substances abuse. And remember, everything in moderation, because a little bit of alcohol is not bad. It actually can be helpful. I'm not opposed to people taking cannabis. I'm not opposed to people having any form of drug, to be honest. But the problem is that we have to not be judgmental, and we have to make sure that to protect yourself, if you don't feel comfortable with it, to make sure you don't get involved in that. And this is a heart. And you'll see there's a nice fresh thrombus in the main coronary artery, which has caused this healthy 43-year-old male, but he had raised LDL, low HDL, the so-called good cholesterol, type 2 diabetic, hypertensive, but he had a normal BMI. Because remember, BMI is about height to weight. So if you've got a short muscular guy, he may have a high BMI. So I would advise also, just to make your life easier, you don't have to do too many calculations, waist circumference. And it's really for guys, it's about 96 centimeters. For women, it's about 86 centimeters, which is not much, by the way. But if you increase above that, you're going to be producing more of these cytokines. And if you follow the big 5, you'll be able to defer this and not have a heart attack. Because remember, 50% of people who have heart attacks, strokes, loss of limb had no symptoms before. It just happened suddenly. So we need to make sure that we investigate our patients early, explain to them that they should be getting their blood pressure checked, their sugar, their cholesterol, exercise, make sure their waist circumference is well, so that they don't actually end up with a heart attack, stroke, loss of limb. And this is the problem, metabolic syndrome. I love this picture because it expresses so many parts of what we're talking about. You'll see the guy with his waist circumference sitting on a chair. He loves it. He loves his dog, but he doesn't love himself enough. So he's exercising the dog on a treadmill. But he also has two other things, a high fructose caloric drink in his left and a remote control on the right. And let me just, when the Surgeon General in America decided, also was worried about the childhood obesity issue in America, there were two recommendations that they made. One was to decrease the numbers of calories, particularly of fructose issues and stuff like that. Remember that if you have 2 cans of a fizzy drink or you have an excessive amount of fat, they actually cause, they go to a place in the brain called the satiety center, but it doesn't tell them anything. It says that, listen, I'm still hungry even though I've had 2 of these drinks. And if you had 2 of these drinks, you have the same number of calories as a full meal. But if your brain doesn't recognize it as food, what are you going to do? You're going to have another plate of food and say, oh no, and then you're wondering why increasing weight. First, decrease the numbers of calories, particularly of high caloric fructose type drinks. The second is the remote control. And what he said is that 2 or 3 times a week, remove the remote control from the child. The reason being that the children, not because TV makes people fat, although it can, and it can definitely make some people stupid, but the point is that it's just so that the kids can stand up, walk to the TV and press the button. You really don't need to do too much exercise to make a huge difference to your life. And so what has that got to do with sex? Okay, we're gonna touch on that now. Okay, first of all, remember, again, the big 5. There are 5 things that are important. It's a biopsychosocial cultural model that's important for all sorts of sexual activity. The biology of some people are predisposed to hyperlipidemia, psychology, the way you think about, and I always like to say that there are only 2 sexual problems that you should judge your patients on. Only 2. One, and they're probably the same, by the way. One is taking somebody by force, rape. That's unacceptable, and violence with gender-based violence is unacceptable. Number 2 is taking a child, which is a form of rape, of course. But besides that, I think we have to keep an open mind that everyone has their own fetishes, they have their own issues, they have their own sexuality, and if you're having consenting people doing what they like, enjoy it. I'll give you an example. I had a patient, a couple, they were married, they didn't have children, but the problem was that the husband couldn't ejaculate unless there was a red stiletto next to his wife's face, wife's head, basically, while having sex. So she thought this was disgusting and refused, so he could never ejaculate because it was a psychological thing that he had. I told her, but listen, the stiletto doesn't get worried by this sex thing, so why don't you just put it there? They've got 2 kids now, so I'm pretty sure there's a stiletto involved somewhere in this relationship. And of course, men are always accused of having brains like this. All we're doing is thinking about females or whatever, males or whatever. But I can tell you this is a complete lie, complete. It's actually more complicated than that. In fact, females think about sex more than guys. Guys think about it every 13 seconds, females about every 11 seconds. So we also have to recognize that we are actively sexual organ people. We're supposed to be having sex. It's a good thing. You don't have to, but if you want to do it, and whatever you're doing, provided you're not doing those 2 things, get on with it. Masturbation is perfectly reasonable. Excellent stuff. The only difference between masturbation and penetrative sex and couple sex is that you don't get the intimacy, but you still get the benefits of the release of oxytocin, the release of the exercising, because remember, sex is a form of exercise. In fact, if you have sex, maybe a male or female, for 15 minutes, 3 times a week, you can burn off the equivalent numbers of calories to a Big Mac meal. Although you should probably not be taking a Big Mac meal, but sex is a form of exercise. But guys, again, we're disadvantaged. Our best directions for guys between the ages of 18 and 22. After that, we all start deteriorating to the point where eventually even the beatings from a partner will not raise this thing. And that's where you need to get some treatment. And you have to make sure that you're not going into a cardiac event, because erectile dysfunction is a precursor to cardiovascular events. Females, by the way, their peak sexuality is between 39 and 44. So if you are not making sure that you're taking care of your general health, which will affect your sexual health, as you go progress, if you are in a heterosexual relationship, your partner is going to outperform you in the future. And on top of that, remember that I was like well, I'll give you the joke just now, but the guys are pretty much an up and down thing. We want to get penetration, body, this, that, the other. And the average guy ejaculates within 3.5 and 5 minutes. It's American data, so I'm sure in the Czech Republic and in Africa, we don't do that. But the point is we ejaculate in not that long a period of time. Only 20% of females have orgasm from penetrative sex alone. 20%, very few. And even if they do have orgasm from penetrative sex, it takes them between 21 and 25 minutes. So foreplay, interactions. Females everybody needs to have a good ambiance to get to function sexually. And like they say, a guy can have sex when he's angry, but a woman will never have sex when she's angry. So foreplay, and that brings me to my joke that the couple who were divorcing, and the wife says, and in 20 years of marriage to you, I faked orgasm every time. And the guy says, well, that's fine, because in 20 years of marriage to you, I faked foreplay every time. Even if you have to fake it, make sure that you interact. Ask your partner, male, female, whatever you want, whoever you're with, what they like, how they interact. Because a lot of people will say, oh no, I'm sure my partner is not comfortable and is not happy, but you haven't talked to the person. You have to interact. The biggest sex organ is the brain. Interact with each other. Which brings us to anatomy lesson. And I'm sure this is not what you wanted, but it's part of what we're going to be doing. It's going to be interesting because this is a side view of the pelvis, as you see. Most of what the penis is made of is the corporal tissue, corpora cavernosa, corpora being body, of course. What happens when we get an erection as guys? A big blood vessel goes to the bottom part of the sponge, pushes blood into the sponge, and then doesn't let the blood come out because of venous kinking on the tunica albuginea covering the corpora. So what has that got to do with general health? Well, a couple of important things. First, I'm going to show you a bit about the cardiovascular problem that might be that why erectile dysfunction is an issue. But second of all, near the end, just for just so you can use it at the bar, I'm going to tell you that there are actually 3 erectile tissues in the body. 3. One is the penis. One is the clitoris, because the clitoris actually is exactly the same functioning organ as the penis. And in fact, it's exactly the same length, by the way. And I'll explain just now how we came to that. It's a fact that they're exactly the same length. So your penis is not bigger than the lady's clitoris, by the way, okay? But I'll talk about that now. And the third one are the nasal passages. That's why 20% of people who have sex or orgasm have stuffy noses. It happens. And if you're taking one of the PDE5s, the Viagra, the sildenafils, the tadalafils, and the vardenafils of the world, you can get stuffy nose from that. And it's one of those things that's interesting to note. But erectile dysfunction is a marker for cardiovascular disease. I always tell my patients that diabetes is not about sugar. Hypertension is not about blood pressure. Hyperlipidemia is not about fat. What it is, it's about damage to the endothelium, the inside coating of your blood vessels. Because when you get damage to those, you get atheromas, which can then block blood, which then causes you these problems. And what's happening with sugar diabetes? The sugar is actually damaging the endothelial cells, causing scars. Hypertension, it's causing shear stresses, the force causing damage to the endothelium. Hyperlipidemia is implanting into the plaques, causing blockage, atheromas. So if you have an atheroma, equal size penis, slightly smaller than the penile artery, slightly smaller than the coronary artery, which is slightly smaller than the internal carotid to the brain, which is slightly smaller than the femoral artery. A red blood cell can go through the femoral, it's fine, through the carotid, through the coronary, it'll block up in the penile. So we know if you have 3 months of persistent erectile dysfunction, because again, guys, we're always thinking that no, we're not performing enough. Everyone has failures. Everyone has failures. relax. Okay, it happens. We premature, we ejaculate quickly sometimes. If it's not consistent, it's just part of the process. But if you have consistent erectile dysfunction for more than 3 months, you're at a 5 times increased risk of getting a heart attack, stroke, loss of limb, and also cancer, because cancer, because of the inflammation, is promoted by atheromas and problems with the vasculature. It's not a Mickey Mouse thing. Sexual health is important, both for male and for females, and for all the genders in between. And it's not difficult to understand when you consider that the exact same causes of erectile dysfunction are the same as cardiovascular disease. Aging, as we get older, happens, but remember, it's not about chronological age, what your ID book says. It's about your physical age. You have to make sure that you maintain your physical age. I've got patients in their 40s who look like they're going to die in the next 5 years. I've got patients in their 90s who look like they might live for another 20 years. It's about taking care of your health, the big 5. Smoking, I'm not going to pontificate again. Diabetes, hypertension, depression. Depression is such a big issue. It's probably the biggest leading killer of people, even patients with cancer or heart attack, they are more likely to get depressed. Depression is a huge issue. It's nothing to be pushed under the thing. We must bring it up with our patients and for ourselves if we're under depression, we're getting depressed as well. Hypertension, obesity, physical inactivity, and HIV, especially in Africa, it's a big thing. It's a neurotropic and a vascular-tropic virus, so it can cause damage to your blood vessels, cause you sugar diabetes and heart attacks and all these sort of things. And again, the other things like, for example, sedentary lifestyle, diabetes, it all translates into cardiovascular disease. And the big 5 that you need to remember is, again, cigarette smoking, depression, stress, which is leading completely, physical inactivity. Let me just touch on that quickly. I said earlier that you only need to do 3 minutes of exercise per day. And that's based on, because we're scientists, guys, we're scientists and artists and we're going to do medicine. But that's based on a randomized trial done out of the University of Birmingham. What they did is they had 3 cohorts. One was patients doing 3 times a week. The subjects were doing 1 hour and 20 minutes of exercise 3 times a week. Why 1 hour and 20 minutes is because if you exercise more than 1 hour and 20 minutes, we know that it increases the amount of cortisol, which can make you age more quickly. Doesn't mean if you want to do ultra marathons, you must stop, but you must remember you don't really need to do that much, that more than 1 hour and 20 as a general rule, and it may actually be counterproductive. Second was 25 minutes of exercise 3 times a week. And the third was high intensity intervals training. Basically 20 seconds of vigorous exercise, whether it be rowing or running, whatever, 20 seconds of rest, 20 seconds of rest, until you've done it 3 times. So 3 minutes, basically, of this with the rest and everything. Outcomes were about cardiovascular health. All 3 came out equal. You don't really need to do too much. It doesn't mean I do more exercises than 3 minutes, but technically you could be in a suit and do the high intervals training for 3 minutes. But the point is you need to do some form of physical exercise, and it doesn't have to be too much. Poor diet, quantities, quantities, quantities. One of the other tricks that you can tell your patients, besides cutting back on numbers of calories, is plate size. Let me put it this way. If you go to your grandmother's house today with your plates, they won't fit in her cupboard because plate sizes have increased by 50% in the last 30 years. And it's easy to understand. If you've got a small plate of food and you eat it, you're satisfied. If you have a big plate of food, you eat it, you're satisfied. Smaller, fewer calories, fewer calories. Drug use, including alcohol. I do drink alcohol, and I've got very good Czech beers. I love them. I love those beers. I've been to Prague many times, and I love it. Oh, great. And the food, oh, brilliant. Then the alcohol is not directly related to sexual dysfunction, except for a couple of things that can happen to both men and women when they drink alcohol. And that's that 80% of men and women who drink alcohol will fall asleep while having sex at some stage. Okay, so it's probably best to try to cut back again. But all types of drugs, you must, any sort of substance that you're taking, try to limit it or to cut it out to the minimum that you can manage. And as I said, sex is a form of exercise. Which one would you rather have? A brisk walk or a bit of sexual activity? I don't know. Orgasm or washing windows? Sex is good for you. And this is what brings us to the fact that sex should be a lifelong thing. Because less is more. Less stress, fewer calories, less sedentary activities, fewer drugs. These are important. You have to make sure that less is more. But having said that, erectile dysfunction is not the only thing that's impacted by general health and by your sexual health. Decreased libido, almost always related in men and even in women, because remember, testosterone is what causes females to get sexually stimulated. It's not estrogens, it's testosterone. They get dihydroepiandrosterone from their adrenals. That's what causes them to have the arousal and desire of sexual activity. We'll talk very briefly about female sexual treatment used with testosterone a bit later. But libido has to be assessed. Libido is related to morning erections for guys because they're both related to testosterone. As guys, we've got three types of erections. One is the psychogenic one, the one that causes that you normally think, oh, I'm turned on by somebody, I'm going to have sex. The second is reflexogenic, which is basically a reflex. And that's why the majority of paraplegic patients are usually young and they're still able to have sex, because all they have to do is they pinch the tip of the penis, the glands, or pinch in the anus. It causes a reflex, which can cause an erection as well. The third one is the nocturnal, the night erections, which we suspect is basically mainly due to testosterone levels. That's why all young baby boys, even at birth, you know that 50% of vaginal deliveries, if you were to, I don't know who did this study, but they found that 50% of boys who are delivered vaginally will have an erection when they come out. So I guess technically they're not virgins, but at the end of the day, it's because they need to get increased blood oxygenation into the penis, because when it's flaccid, it's relatively hypoxic. Once you get an erection, it increases the oxygen. But if you keep the oxygen, because of the venous blockage when you're getting an erection, it can become hypercapnic if you leave it for too long. That's why if you have an erection which is lasting more than about 3 hours, it's called priapism. It needs to be addressed because you can also damage your penis from that. So libido, super important. Premature ejaculation, by far the most common sexual problem for men. 80% of us guys have premature ejaculation, which by definition used to be either before penetration or within 30 seconds of penetration. But the DSM, the Diagnostic and Statistical Manual, have changed that. It's about the perceptions. If somebody thinks that, no, I'm lasting for 10 minutes or 15 minutes, but it's not enough, it's premature ejaculation. You can be treated. How is it treated? There's only one drug that's been FDA approved for premature ejaculation, and that's duloxetine. But off-label and much cheaper is to use SSRIs, serotonin reuptake, or SNRIs, serotonin noradrenaline reuptake inhibitors, off-label to treat it, because it increases the serotonin, because serotonin is the most important part of determining how long you will last sexually. Usually it's best to give it on a daily basis, although there can be some side effects, a bit of fatigue, dizziness, and that sort of thing. And it can be used on demand. There are lots of them. You can use sertraline, you can do all of them have pretty good evidence, but probably the one with the best evidence is paroxetine, and they work very well. Also keep in mind that 20% of all men have congenital premature ejaculation, which means from the first time they've ever had sex, whatever age it was, they were having premature ejaculation. It's a huge stress for patients. It has to be addressed. Usually with that, there are other things like the pinching method, and you can also use local anesthetic creams, but generally medical treatments are pretty effective. Other ejaculatory problems, remember, most of what a guy ejaculates is not sperm. 1% of what we ejaculate is sperm. The rest is produced by the prostate and the seminal vesicle. So if you have a prostate problem, if you have had operations, it can cause a problem. So you need, and if you're putting them on treatments for BPA, for benign prostatic hyperplasia and things, that can also be an issue. So just keep that in mind. Fertility issues, it's a huge thing. Fertility, 15% of the world's population has fertility problems. It needs to be addressed. If you aren't having sex, you aren't getting erections, it's going to be causing a problems. And almost all are more common in the elderly. And I repeat, it's not about chronological age, it's about your physical age. And even saying that, there's French data to show that if a man over the age of 60 has sex twice a week rather than twice a month, because the average couple in America, again, has sex 2.5 times per month, okay, married couples. But if you have it twice a week instead of twice a month, you, barring all the other comorbidities, you increase your longevity by 6 years. 6 years. Just from having more sex. A form of exercise, it's good. It also improves the mood. It does. Sex is super important. For females, it's even better. You get 8 years if you're having sex twice a week rather than twice a month. Don't consider age as a barrier for your patients to have sex, because you must. And the way you're going to make sure that you save things for your retirement is by big five. But what treatments do we have besides the underlying? Because whether we like it or not, we will start having some problems as we get older. And you don't want, when you get to the point where you're getting old enough to have problems, you need to be assessed for sugar, blood pressure, lipids, exercise, smoking, diet, and then you have to consider treatments, because you don't want to be the guy who, when you're a kid, you think about rabbits, you get a bit older, you think about food and rabbits, then this is probably where most of you guys are now. You're thinking about women and food, or maybe a bit of women and alcohol as we get a little bit older, my sort of age. But eventually, if you don't take care of your health, you're going to end up thinking about food and alcohol eventually, but eventually you'll end up just thinking about rabbits. You don't want to reach that. You can change it by doing the big five. And low testosterone is a huge thing. Hypogonadism has got guidelines. We know that there's things that are important. Testosterone is super important for patients and for guys. I know there's a lot of data, FDA black boxes and stuff about testosterone supplementation. We're doing a lot of work on this, on testosterone. Testosterone is necessary, both for men and for women. And if you have testosterone deficiency syndrome, you're at an increase of all these things: erectile dysfunction, diminished nocturnal erections, reduced sexual activity. But look at this: increased visceral obesity, the metabolic syndrome again, huh? Interrelated. Decreased lean body mass, more loss of muscle rather than fat, which means that you are sarcopenic, dangerous. Actually is related to cancer-related deaths if you have sarcopenia. Metabolic syndrome, insulin resistant, type 2 diabetes, it's all interrelated. And how do we check if they've got a hypogonadism? You ask patients about their nocturnal erections, how their sex life is. We know that from age 30, about 13% of guys have a low testosterone. By the time you reach 80% of guys have low testosterone. It's affecting their sexual health, it's affecting their general health, because testosterone has effects which are necessary. And it's not a wonder drug. Not everyone needs to have it. You have to have a level below 12 nanomoles per liter. It's a morning specimen because there's a circadian rhythm. And that's why we get the morning erections, and the babies get most of their 8 to 13 erections, more than adults. The kids are getting more at night mainly. And you usually also have to do a hematocrit, because anemia and polycythemia are related to testosterone. If you give testosterone supplementation, about 1 to 3% of guys will have an increase or get polycythemia. It's usually not dangerous, but it's something to keep in the back of your mind. But if you do that, that's pretty sufficient, because you really don't need to be doing FSHs, the follicular stimulating hormone or luteinizing hormone, as a standard of care for the average person who comes in with sexual dysfunction. It's just the testosterone and maybe the hematocrit, because testosterone has lots of effects. But to make it simple, let's put it this way. If you have a normal testosterone, which is decreasing as we get older, and in patients as well. If you have a normal testosterone, your cells will go towards muscle. And that's why some of your patients will come in and say, oh no, I'm exercising, I'm dieting, and doing everything grand, but I'm still gaining this visceral obesity. Look at the testosterone, especially in older men above the age of 40, 50. Because if you have low testosterone, your precursor cells are going to go towards fat. And what is this going to do? It's going to cause you to damage your endothelium, which is then going to cause you to get a heart attack, stroke, loss of limb. It has to be addressed. And Is it safe though? Because a lot of people can say, oh no, but you're giving testosterone doesn't increase cancer risk, it isn't going to cause you to have prostate problems. The reality is that the prostate, which again is sitting just below the bladder, all the way around the pipe for passing urine, the urethra, 30% of what we ejaculate is there. The other 70% is coming from the seminal vesicles, sugars, bladder, that sort of thing. It's the commonest site for cancer, as we know, after skin cancer, right? And it's also the third leading cause of death from cancers. The number one leading cause of death from cancers is lung. What's the main cause of lung cancer? Smoking. It's interrelated. Take care of your general health, but take care of your sexual health as well. And there's some risk factors for prostate cancer besides just aging. Family history, if you've got a patient who's a family history of any sort of cancer, but most particularly first-degree relatives with prostate cancer or breast cancer, because they're very related to the gene actually, BRCA2 is one of the big genes involved in prostate cancer, we know. So if you have a family history, you're at an increased risk. If you are having a high-fat, low-vegetable, in other words, high-caloric diet, you're more predisposed to getting prostate cancer. Megadose vitamins versus exercise. Again, this was probably one of the biggest, most expensive trials ever done. It wasn't, you probably have never heard of it because it was sponsored by a megadose vitamin company, which was trying to sell their product and use it as a wonder drug. They were comparing megadose vitamins to exercise and normal diet. Out of the 3 cohorts, the one that came out worst was megadose vitamins. And we think it's because you say, okay, you need zinc in your diet, but how much? 500 milligrams. We don't know, okay? But what came out first, it actually, the megadose vitamins actually increased the risk of heart attacks, strokes, loss of limb, and cancers in patients compared to normal diet without the megadose vitamins. I'm not saying don't take a vitamin, but the recommendation at the end of this was that if you are going to take it as a man, a vitamin as a man, take the female vitamin because it's got a slightly lower dose. What came out first? Exercise. Decreased diabetic rates by 50%, decreased cardiovascular risk 30%. It's huge. Exercise, exercise, exercise. I like the marriage and sex one because I'm not married, but I do like sex. But most of my friends are married, and they say that since they got married, they're having less sex. So I'm not sure how this is interrelated, but the point is that if you are married, you have a lesser risk of prostate cancer, and the more sex you have, again, decreases your prostate cancer risk. Infections, STIs, urinary tract infections, big things as well, need to be addressed. Dihydrotestosterone inhibitors were initially vilified as causing more aggressive cancers. They've now been shown for active surveillance patients or with prostate cancer to actually protect progression. They're pretty good drugs, but they're not wonder drugs. They're not going to prevent you getting cancer without the other aspects. Cooked tomatoes, and again, we're scientists, so always keep your mind open. Always look for confounders, look for issues that with the trials. Cooked tomatoes do decrease the risk of prostate cancer by a little bit, not much. But when you look at who sponsored the trial for the cooked tomatoes, it was Dole Monsanto, biggest fruit and drug company in the world. Huh? And what's their biggest seller? It's the fruit, not the vegetable, canned tomatoes. Because lycopenes are coming from cooked tomatoes, which are canned. Like canned tomatoes are a form of food. That one does. But what they didn't tell you is that if you really want to increase your lycopene intake, you can get about 100 times more lycopenes from melons. But they don't sell, they're cheap. So you don't get, keep your mind open. As scientists, artists, we need to keep our minds open. Testosterone has now been shown, if you have a low testosterone, you're more likely to get a nasty form of cancer in many ways, statistically. So I'm not saying again that you have to supplement everybody, but you have a low testosterone, it's there's no danger in giving testosterone. They probably are protecting them from prostate cancer. And of course, race. Black men are about 5 times more likely to get prostate cancer, and they're more likely to die from prostate cancer. It's a lot of things. It's about equity, insurances, and various other things, but it's also about genetics. And we're doing a lot of studies on genetics, which hopefully in the future, you'll also participate and you'll help us with some of these trials. So what do you do for the prostate cancer? Before your patient comes in, you have sexual health is simple and general health is simple. You just need to do the normal things for everybody. History and examination, including blood pressure. Digital rectal examination, we've published now that it's probably not, it's not got level 1 evidence, by the way, and only about 3% of nasty cancers are going to be picked up by a DRE. So what a lot of guys don't want to have a DRE. We're stupid like that. Women go for cervical pap smears with speculums and stuff, and we were worried about a finger for a few seconds. But if you really don't want to have a digital rectal examination, the PSA does have level 1 evidence. So it's important for you to remember, you ask them a little bit about sex. There are only 3 questions you need to ask about sex. For guys, how is it in the bedroom? If they say everything's fine, you forget it. If you do have a problem, what is the guy not standing? How is it not standing at all, or what's going on? The penis. Are you ejaculating too quickly? Because it's a different thing. It's not going to be treated by the medications that we use for erections. And third, how are your feelings for sex? And do you get the erections in the morning? Testosterone. You do these few blood tests for a guy over 40. Literally 10, 15 minutes after you've had his sexual check, you've checked your prostate, checked his general health, he's out of your office. Simple. Very, very easy. And that just finally brings us to the partner. Because remember, although there's no danger or problem in having sex, masturbation, living your own sex, or not being asexual completely, that's perfectly reasonable. But if you are in a partnership, you need to remember that they also will have their own issues. And when it comes to heterosexual relationships, you'll notice that all of the things that women have are caused by men. Menopause, menstrual pain, mental illness. They have to go see the gynecologist. And then when they remove their hysterectomy, we're the cause of a lot of the problems for females. And women, as I said, are much more complex, much more efficient organisms, if you ask me. Got a lot more facets besides just the up and the down. And their organs are different, but similar. Why I'm showing this is I tempted you earlier about the length of the clitoris. I'm going to tell you a trial. You're medical students, so you've lost out a little bit because these were done in medical students at the University of California, San Francisco. They were paid to have sex in a functional MRI. Cool trial, and paid to do this. I mean, which guy and woman would? Anyways, the point is they were paid to do it. What we were looking for the G spots, and we found that there were 3 G spots in females, where there's increased blood flow, increased nerve activity when they're reaching orgasm. One was the clitoris, which runs in a loop around the vagina, which then makes it the equal length to the penis. Same length, one of the organs. How do you stimulate that? It's similar to the other, to the penis. The mental way you're thinking, licking, touching, feeling, being nice increases blood flow. And by the way, we use PDE5s in patients, even females. We off-label for vaginal arousal and things like that. The second one was on the anterior wall of the vagina, the one where that German guy identified. There was an increased blood flow. So technically, if you're doing doggy style, you might be hitting a G-spot a bit more than if you're doing missionary. The third one was interesting. It was actually the bottom part of the cervix. If it's gently stimulated, gently, not violent. This is the whole point. It's not about thrusting for guys. You have to gentle, foreplay, gentle, good. What we did with them is that we actually put little cameras on the tips of the guys' penises, okay, until we could look and see what was happening to the cervix. It's science, guys. You see how fun science can be. What it showed is that the womb, the cervix is pulled down by the female during orgasm towards the penis. And we can get stimulated down there. Of course, being scientists, we say, no, it's coming down to collect the sperm and things like that. But the reality is that it looks like an elephant trunk, basically, when it's coming down there. And again, it just goes to show that we guys are not the most efficient, because we always say, oh no, I felt your womb, the lady's womb, so I knew that my big penis was damaged. The woman was pulling it down for you, by the way, if you're giving her orgasm. So we're not so great, guys. Okay. So remember, there's sexual differences between men and women. Men, genital focus, performance oriented, orgasm mandatory. We don't like tactile stimulation as a general rule. Our testosterone levels are there. Women, intimacy focused. Sex is viewed in a broader context. Orgasm is optional. You don't have to have orgasm. Visual stimulus is often distracting. Get rid of the TV in the bedroom. Tactile stimulus is excellent. They want to be touched. And we are using testosterone in females as well in about 1/10 of the dose, only on trial for specific conditions. It's not as simple as with guys. So remember to take home, good erection is a neurovascular reflex. Good sex is subjective, cognitive experience. It involves complex interplays of emotional relationship and psychological factors. And it involves the complex interplay of usually of 1, 2, 3 or more, depending on what you're doing, because again, non-judgmental, but a good erection is not good. It's not the same as good sex. And if you're not satisfying your partner, and this is not only for females, it's also for males, you are going to affect your partner if you have a partner, if you have a sexual dysfunction. You're going to have libido problems. They report their own sexual problems, orgasmic issues, pain when having intercourse, vaginismus, arousal disorders. It's a huge thing. If you're not treating yourself, you're not taking care of yourself and your patients, it's going to affect the partners. And our biggest problem as physicians is that we're uncomfortable talking to our patients about this. So if the one point you can take home tonight is that if you have a patient with sexual dysfunction and you don't feel comfortable discussing it, which is reasonable, it's your prerogative, at least refer them to somebody who has an interest in sexual function. And with that, you should come to a nice balance where sexuality, general health, physical health, exercise, everything is all interrelated. And this should be the final precursor of what we should be doing, having great sex, not just for heterosexual, but all genders, all types of people. With that, thank you very much. And if there are any questions, I'll take them now.
Thank you very much for that talk. It's been very informative. If anybody has any questions they don't want to ask publicly as well, feel free to just private message the UIMS account and I can read them out for you.
The other option is you can always, you can also email me. I don't want to have too many floods of emails, but you can also email me and I can answer any questions if there are any specifics that are wanted. And Leila has got my email address, so you can ask her for the email address.
While we're waiting for questions, I've also just put a feedback form in the chat, so I'd appreciate if everybody could fill that in. It'd be very helpful.
Adjusting the position, there we go.
We've had one question privately. Would you ever recommend somebody to have more sex if you feel it would improve their outcomes? Like almost prescribe it?
Yeah, no prescriptions. There's nothing to be prescribed when it comes to sex. It's about what you want, what you feel comfortable with. And each person is different. Some people, I mean, the guys who have sex, let me turn on the light. It's getting dark here. Yeah. The amount of sex is not really that important. And it's really about, let's just put it this way, that if you're trying to have a child, the frequency of sex is important. It's you should be having sex about every third day. The reason being that every time a guy ejaculates, your sperm will live inside the vagina of a woman for about 3 days. But if you're having sex 10 times a day, what's going to happen is that you're just going to decrease the numbers of sperm in each ejaculate. So it doesn't really make that improve your fertility. But having said that, it's all about how frequent and how enjoyable if you want to have sex 10 times a day, hey, if it's not into you, I don't know when you're going to find time to do your studying, but it's nothing dangerous. And if you're having sex once a month, if that's what you're comfortable with, get on with it, because the biggest killer is stress. So if you don't want to be doing it more than once a month or something, that's comfortable. But I wouldn't prescribe anything for anybody. I would tell them to talk to their partner if they're having, or talk to themselves if they're having sex with themselves, or masturbating or whatever, and decide what they want to do. So it's not, there's nothing prescriptive about this.
Thank you very much. We've had another one of how would you encourage patients to feel comfortable and create an environment to discuss these things when people are quite awkward? Would you just start with open-ended questions? Or especially with men want to talk about it?
It's super important. I'll give you data as well. If we know that only about 5% of physicians are comfortable talking to their patients about sex, 70% of patients are comfortable, they want to talk about sex, but they just don't know how to bring it up. So my advice is that sexual health is super important, and it's going to lead you to so many other things, and it's going to prevent you from what they call the doorknob question, where they come in for a 20-minute consultation, and then just as they're getting to the door, it says, oh, by the way, my erections aren't really working. Now you have another 20 minutes. Bring it up. If you say, listen, do you want it to, the best way is just to say, do you feel comfortable about talking about it? It's not related, because most of them are going to come for other reasons for the majority of doctors. But just when you're finished discussing their diabetes or whatever, you ask them, do you feel comfortable about talking about sex? Says, yeah. Are you having any sexual problems? Yes. No. If they say yes, the three things: erections, premature ejaculation, libido, morning erections, you're finished. You can get those things. You just send them for testosterone if they do, regardless of what their sexual issue, you, as a general rule, if they're over 40, and then see. But you have to remember that the majority of patients do want to talk about sex. It's an important thing. It's integral to human activity. And if you're having problems, and the worst part is that we focus on the internet, the TVs. We talk to our buddies in the bar. Everyone is performing like a maniac. We're pumping for days, but garbage. We go, also, one of the things for guys, remember, your penis is normal sized, okay? This small penis thing, it essentially doesn't exist, okay? I've only done a penile enlargement 9 times in my 33 years as a urologist, and they were all for patients with intersex. Because one of the little tricks, if you do decide to get into sexual medicine, is to avoid doing penile enlargements, which is basically we do a cut on the frenulum, because remember, about half of this corporal tissue is buried underneath the pubic bone. We cut the suspensory ligament and pull the penis forward a little bit so it looks longer when it's flaccid. But when you get an erection, because there's no fulcrum, it won't stand up, it'll just go straight. But you can also cause erectile dysfunction. We also inject fat around it to make it look thicker, but it can look bumpy and messy. I'll tell you why you should not do it, because litigation is huge. The most litigated procedures in the world are both urological. One is vasectomy, because in America particularly, the physician has to chase the patient up to make sure that they don't do a semen analysis after 3 months, because remember, it takes about 3 months for you to empty the sperm that are sitting in the vas when you do a vasectomy. And in America, if you don't find the patient and the patient has a baby, they are allowed to sue you. So they have to chase it. Hopefully, I don't think in your country it's the same. Here, we don't have to force them as well. But but the most litigated operation, penile enlargement. 75% of guys who have a penile enlargement operation will sue their doctor, because it's in the mind. They're already psychologically deranged. And we go into the bathroom, we're peeing, and you know physics. If you're going to be looking at an angle, another person will look bigger when you're from an angle. Relax, your penis is fine. Use it appropriately. That's what you must do.
Thank you. We've got one more. Society makes it seem that a man's ego is at risk if he can't get a woman to orgasm. Given that it's much harder to make a woman orgasm, it takes longer. How would you go about encouraging a healthy relationship with sex and his own performance with his partner?
Talk to the partner. As I said, only 20% of women get orgasm from penetrative sex. And the sex is about a whole experience. Foreplay can start a week before when you send a bouquet of flowers. It's a huger thing. You're never going to be able to perform. And by the way, women are excellent at faking orgasm. It's very easy for that to happen. Guys, you usually can tell that you've orgasmed unless you've had a prostate removed or something. You will see some semen coming out. The woman will know. So talk to the partner. Talk to yourself. Discuss. Make sure that you understand. What do you like? Where do you like? No, today I don't feel like orgasm. They can happen. It happens very frequently. All I want to do is to cuddle, and you can penetrate. That's fine, but don't worry about my part. I've enjoyed the cuddling. Talk to your patient, to your partner. You tell them to talk to the partner.
Thank you. That's been really useful. We've had another one of how do you recommend starting such a conversation with your partner if you are feeling inadequate?
You have to start being comfortable. That's the important thing. If you're not partnerships, and then I'm not a relationship specialist, you'd have to talk to somebody who's a relationship. But the point is that if you're not comfortable to talk to your partner, you should really reassess your position with them, because are you being dominant or aggressive, or is she being dominant or he being dominant and aggressive? You have to, if you really are keen on keeping a relationship, and if it's a one-night stand, obviously you don't really need to worry too much, I suppose. But if you're looking to spend time with a person, you need to have a discussion at some stage about your sexuality and what you like, because you don't know what the person likes. You don't know what I think I like. I've got my fetishes, by the way. I've got some fetishes. But if you don't talk to me about it, and as a partner, you're gonna have a problem. So it's about whether you want a long-term relationship with this person, or you want to have a comfortable relationship. If you don't, then don't bother to talk. But if you do, I would advise, even if you think you're satisfying your partner, to have a discussion. Do you really enjoy this? Is it really what you want? How do you like it? Each person is different, and I mean, for example, in East Africa, only 70% of women will only come if the guy uses his penis on the clitoris as a hammering it. It's part of their culture, and that's what turns them on. If you're going out with a person you didn't know that that's what they like, and you're just penetrating, you're not satisfying the person. Talk, talk, talk. Use your brain.
Thank you. There's just another one. Sorry. Is there any research showing the long-term effects of masturbation compared to normal sex?
Yeah, I think that question, the query is coming probably because they saw that data came from the University of San Diego, California, San Diego, where they investigated about masturbation and whether it affects their sexual health of people. Remember, that was done in a VA hospital. It was sold military people basically. And it wasn't a huge trial, and it did say that no, if you masturbate a lot, you're less likely to have normal sex. The short answer is no, there's really nothing wrong. I'll even give you an example of how we're so obsessed with masturbation and things in societies. The reason why circumcision is such a big thing in the Middle East and in Israel, amongst the Jews, is not because of sex, it's because of water. It's about having the circumcision so that the smegma can be cleaned. So that's the main thing. Why is circumcision bigger in Western things? It was introduced by the British in the 1800s because they wanted to prevent boarding school boys from masturbating. Doesn't stop them. It doesn't stop us from masturbating. But the point is, it's a mindset. The short answer, if you're comfortable with your sexuality, get on with it. Only two problems: rape, child. Anything else, get on, and it's good for your health, by the way. It's not going to affect you having babies and stuff, and you're not going to grow hair on your hands. Garbage, all garbage.
Okay, thank you. Sorry, there's just a lot of questions. I'm trying to categorize them. We've had one. What is the most common thing you see in the clinic in kind of younger men and then older men, and how do you deal with them?
Yeah. By far the most common sexual problem in younger men, that's below 40. I put the cutoff at about 40 because when you reach 40, 50% of guys are going to have erectile dysfunction. And below that, the biggest problem is going to be premature ejaculation. But remember, premature ejaculation also increases as we get older. So it's another question you should ask them. I think the important thing is that most of the guys if a young guy comes into my clinic, I can already tell that there's only a couple of things he's going to be complaining about, and sexually, and it's going to be premature ejaculation generally. But having said that, I've had patients with type 1 diabetes and even other conditions who have erectile dysfunction in their teens. So I think the important thing is not just to categorize people by age. Ask them the three questions: erections, premature ejaculation, and libido issues. And then you can sort out most of the problems that patients have when it comes to their sexuality, at least for men. Women, by the way, the reason why I've talked so much about men is because we are doing trials for female sexuality as well. It's a huge issue. The problem is that Viagra made us now become more scientific about male sexual health. Because in 1996, you know the story about how Viagra was developed as a blood pressure medication, but when the trial was a negative trial, the guys weren't bringing back the drug, so because they were giving them erections, and that's how they developed it as a drug. But then we started having science, because before that we used to say, oh no, it's mainly in your mind. We now know that the majority of patients with erectile dysfunction, it's an organic underlying problem that needs to be addressed: hypertension, blood pressure. But females, it's now coming to the fore, and that's why I'm talking about, even with testosterone and things, there are trials which we're using them for patients with breast cancer, where we're using it for vaginal lubrication, rather, because they can't take estrogen creams, working very well. It's excellent, but don't categorize. Just for your purposes, for guys, those three things. Ask every guy who comes in, if they're comfortable to talk about sex, ask them those three questions.
Okay, thank you. And I think just one last question, if that's okay. Is there any situation in which you would talk to the man's partner alone to ask them their opinion, or would you always talk to the couple together?
Okay. The first thing is that almost 99% of the guys who come into my office for sexual problems come by themselves. it's fine if that's what they're comfortable with. And I always tell them that they should probably talk to their partners. Some of them don't want to. And again, you don't force people to do anything. But if they both come in, usually that means that they're comfortable. What you should do is ask them, because medical legally you can get in trouble. Ask them, are you comfortable for me to discuss with your partner? And then if they say yes, you're free for all. And it usually works out better if the partner's there, because the partner usually will tell you that no, the guy says, no, I'm ejaculating too quickly. And he or she will tell you, no, he doesn't. There's nothing wrong. I've never noticed. First time of the discussion. If you can get them together, that's ideal. But if they don't want to come in together, that's fine. But if they come in together, the only way I'll kick the patient, the partner out, is by if the patient says, I'm not comfortable talking, then I'll say, okay, he's probably going to get a beating at home when he gets home. But the point is that in general, they won't kick the partner out.
Okay, that makes a lot of sense. And I'm really sorry, we just had one more, if you don't mind staying to answer.
That's fine.
It's a given example that I'm going to try and anonymize. It'll be a bit slow to ask. But if a person was taking SSRIs for a short period, for about 2 years, and then hasn't been taking them for 4 years, and has noticed a change in the intensity of arousal, do you think this could be related to stopping taking the SSRIs, or more likely just aging, change in time, place, situation?
Okay, it's a complex question, and it's really quite difficult to answer without having the exact things of what's going on. But I would say that it's more likely that it's just the aging and things that's going on. When you've taken I've had patients who take SSRIs for 3, 4, 5 years, and then they stop for whatever reason. And usually because I have premature ejaculation, because I'm not a psychiatrist, so I don't give it for that. And a little trick that we do is if you've got medical insurance, I write depression on the prescription, so the medical insurance will pay because it's off label. But some have gone on for 3, 4, 5 years, they've stopped. They notice 2 years later that they're having premature ejaculation again. Restarting it works completely well. So it can be related, but remember, it's a biopsychosocial model. There's lots of issues that are going on here. You must, every time you see a patient, you must make the effort to make sure that you take your history. Don't base it. My fellows, if they come in and I write a letter from my private practice to a patient to come and see them, if they don't ask and do a full history, a full examination on that patient, I will fail them. I will not you can't trust anybody else except you. So get on with a full examination, full history, find your own diagnosis, even if you've got a piece of paper telling you what this senior guy has said. You are the doctor. You're the one who's going to have to take care of the patient, and you're the one who's liable for any problems if you don't focus on what treatments you're going to give them.
Okay, thank you. Sorry, there's one more just coming through. I promise we will stop after this.
No problem.
It's being sent through in a few messages.
No
How
problem.
would you address transgender patients going from male to female who are now considered trans women but have been diagnosed with BPH?
Yeah, it's a bit too complex for tonight, but let me put it simply, that transgender, each transgender person has different levels of how far they want to go. By far the most it's just usually changing their hormonals, getting breasts for guys, for making sure that in females that they get more beards and stuff like that. So the majority are not going to be going for the full hog, where they're going to be removing the penis if they're a trans female, or if they're going to be making a penis in trans male. And by the way, the top transgender surgeon is in your country, by the way, as far as I know. He teaches everybody, all of us, by the way. So anyways, but the point is, so it's a variety. So if you've had, like for example, if you have a transgender who's had a vaginoplasty as well as a penile removal, to find the prostate can be difficult. We haven't got any guidelines, but I would say the short answer is that if you have a transgender, be open, understand what they want, what they're going on, and just treat them normally. We think they have a bit more problems, like with diabetes, some hormones for some people. But if you just do the normal treatment, keeping an open mind, ask them, and if they usually will tell you, if you are open, that they are transgender, what are their worries. Treat them like if it's like, for example, a trans female and they've still got a penis, Talk about the erectile dysfunction. By the way, they still, a lot of them want to have babies and stuff. Talk about doing a PSA. As I said, the digital rectal is probably not the biggest thing. There are lots of things, and for trans males, if they've still got their womb, they still need to be assessed. Just a little proviso here. Remember, please, if you do have children, male or female, please get them HPV vaccinated at around the age of 11. It's brilliant stuff. And why 11? It's not because we think in having sex, it's because of their immune system is best at that time. But the point is, you have to individualize depending on how far they've gone with their transgender assignments.
Thank you very much. I think that's all for the questions. So thank you very much for giving this.
No problem. Thank you for inviting me, and keep me up posted. As I said, you can ask Leila to give me to give you my email if there's any pressing questions. But otherwise, maybe you can just hopefully I've addressed most of them, and if any of your colleagues, they can obviously, because you've recorded, you can do what you need to do with it. Okay.
Great. Thank you so much.
Come to South Africa sometime. I hope you're all. It's a beautiful country. Don't worry too much about our so-called corruption. It is corruption there, but some bits and pieces. But it's a lovely country. Please feel free. And Zimbabwe, the whole of Africa. If you haven't been to Africa, please come to Africa sometime. Okay.
Thank you.
Okay. One other thing, just before I go, we are having if you're interested, we're having a urology summit sponsored by AstraZeneca on the 8th of May. I'll send the link to Leila, and if anyone can join in if you want to. It's going to be a lot of topics. We're talking about prostate cancers and stuff. It might be interesting to you, especially if you're going to become a urologist, because urology, by the way, is the most important specialty. 40% of GPs' work is urology, fertility, erections, that sort of thing. And we can sleep at night. We don't have to wake up for emergencies too often. So it's a good job. Good job. Think about it.
Thank you. That would be really useful. We'll post it on the UIMS socials after you send it to Leila.
No problem. Okay. All right, guys, you have a great evening otherwise. It's Friday night. You must do a bit of partying. Don't be boring. You mustn't spend all your time just studying. It makes you a warped physician. You must enjoy 70% social, 30% studying, but make sure when you're doing your studying, you're focusing. That's the important thing. Okay.
Thank you so much.
Okay, guys. Bye-bye.